British monarch Queen Elizabeth II dies at 96. President Buhari joins world leaders to pay tribute.
President Buhari declares open 12th Nigerian Navy Games, inaugurates sports complex.
The Games should therefore provide a glimpse of what Nigerians expect from the Nigerian Navy.
People's Democratic Party NEC passes vote of confidence on the Ayu-led National Working Committee.
Those in favor of the motion of a vote of confidence on the Yosha Ayu-led National Working Committee, say aye.
And on Good Morning Nigeria today, we shall discuss the life and times of Queen Elizabeth II plus primary healthcare and emergency medical services.
All right. Now, Nigerians generally, but most especially those in rural communities, often do have need for healthcare and emergency medical services, such as women who, of course, we know, may have need for antenatal and postnatal care services.
That's true, Claire. Now, health statistics indicate that most women die from complications during pregnancy. And of course, this is occasioned by lack of access to quality medical care. And this contributes significantly, it is said, to the growing number of maternal and infant mortality in developing countries such as Nigeria.
So the deterioration of the primary health care centers at the local government level has also compounded the challenge of access to medical facilities, while the secondary and tertiary facilities are equally overburdened with influx of patients who ordinarily would have been attended to at the primary healthcare centers.
And that's why the Federal Ministry of Health initiated a program for the rehabilitation of more than 1,000 primary healthcare centers across the country, with Kuchinguru Primary Healthcare Center as the pilot. Now, there is also the National Emergency Medical Services Ambulance Scheme, NEMSAS, which was launched as a government initiative that is private sector driven to save lives and also ultimately create jobs.
Indeed, and NEMSAS was launched in February, I think this year.
I'm not quite sure what it is.
Yes, well, it has been launched February this year in collaboration with the National Health Insurance Authority now. Then it was Insurance Scheme, of course, NHIA, by the Federal, Road Safety Corps, the Guild of Medical Directors, and the Federal Capital Territory Administration. I'm not understanding that again now. So, of course,
well, all of those were included at the pilot stage when the launch occurred in February this year, as you earlier indicated, Claire. Now, in addition to the health issues, as a second topic, we will, of course, be taking a look at the life and times of Queen Elizabeth II, who passed on yesterday at the age of 96 after a 70-year reign on the British throne.
Of course, there have been torrents of tributes and messages of condolence from world leaders, including President Muhammadu Buhari, in honor of late Queen Elizabeth II, who ascended the British throne at the age of 26. Now, we shall also be discussing that in the course of our program. Let me welcome all of you. It's Friday's edition of the program, and it's always a pleasure having you join us.
I'm Kingsley Osadolo. I join my colleague Claire to also welcome you to the program, and because of which we have complimentary segments, business, we hope, and of course, a newspaper review. For now, Anne Jibuno has highlights of the morning news. Good morning, Anne.
Good morning, Kingsley and Claire. Good morning, Nigeria. Here's the news. Queen Elizabeth II, UK's longest-serving monarch, has died at Balmoral at the age of 96 after reigning for 70 years. Her son, King Charles III, said the death of his beloved mother was, and I quote, a moment of great sadness for him and his family, and that her loss would be deeply felt around the world, unquote. Senior royals had gathered at her Scottish estate after concerns grew about her health earlier on Thursday. Prince Charles will lead the country in mourning as the new king and head of state for 14 Commonwealth realms. Camilla, his wife, becomes queen consort. In a statement, Buckingham Palace said, and I quote, "The Queen died peacefully at Balmoral." Prime Minister Liz Truss, who was appointed by the Queen on Tuesday, said the monarch was the rock on which modern Britain was built, providing them with the needed stability and strength. Speaking about the new king, she said, and I quote, "We offer him our loyalty and devotion, just as his mother devoted so much to us, to so many for so long." Meanwhile, President Muhammadu Buhari received with immense sadness the news of the passing of Queen Elizabeth II of the United Kingdom. A statement from the presidency reads, in quote, "My family and I and the more than 200 million Nigerians have learned with immense sadness of the passing of the Queen and the end of her unique and wonderful 70-year reign. Her late Majesty was the only British sovereign known to 90% of our population. Our thoughts and sincere condolences are with the royal family and the people of the United Kingdom and the entire Commonwealth as we join the entire world in mourning her loss. The story of modern Nigeria will never be complete without a chapter on Queen Elizabeth II, a towering global personality and an outstanding leader. She dedicated her life to making her nation, the Commonwealth, and the entire world a better place." End of quote. The president also welcomed the ascension of King Charles to the throne in line with tradition and praised His Majesty will witness continuing robust and sisterly relations between Nigeria and England. Now, President Muhammadu Buhari is urging Nigerians to have faith in the ability and capability of the nation's armed forces to effectively safeguard their collective interest, promising to do whatever it takes towards sustaining the current operational tempo in the fight against insecurity. This was while inaugurating the newly constructed ultra-modern sports complex of the Nigerian Navy at Ojo in Lagos State. The president also declared open the 12th Nigerian Navy Games 2022.
The Games should therefore provide a glimpse of what Nigerians expect from the Nigerian Navy: dedication, commitment, unity, oneness, and comradeship.
The 97th National Executive Committee meeting of the People's Democratic Party has passed a vote of confidence on the Iyocha Ayu-led National Working Committee. The NEC also announced the stepping down of Senator Walid Jibril as the party's Board of Trustees. Chairman for former President of Senate, Adolfo Zumabara, on acting capacity.
Those in favor of the motion of a vote of confidence on the Iyocha Ayu-led National Working Committee, say aye.
This party is famous for settling all disagreements.
They are determined to resolve those internal disagreements.
Meanwhile, the national chairman of the All Progressives Congress, Abdullahi Adamu, says the party is working to end up in the presidential villa and not in the tribunal. He stated this when he played host to Senator Oluremi Tinubu, wife of APC's presidential candidate, and her entourage at the party's national secretariat.
Some of the best brains are amongst you, women. President Buhari will not be on the ticket in 2023, but his spirit and his driving leadership and progressiveness in all that he does, his firm will continue to add value to whatever we're going to do.
We've been busy, quietly, but we want to intimate you on the activities. We're yet to get our organogram fine-tuned.
The Department of State Services says it has executed valid search warrants on Mamu's residence and office. A statement by the Public Relations Officer, Peter Afunaya, indicates that during the process, incriminating materials, including military accoutrements, were recovered. Other items include large amounts in different currencies and denominations and instruments. Amo will have a date in court at the end of the investigation. Well, that's the news for now. Good Morning Nigeria continues with Kingsley and Claire after this break. Thanks for staying.
Every morning is an opportunity to take your hustle to the next level. Every morning is one day closer to your ambition. So, make every morning count. Cup after cup, morning after morning. Start strong, finish strong. Nescafe.
St. Matthew Royal College, a class in the sub-Sahara. Education is not just class teaching, it is a thorough upbringing of the child. Hence, the UNESCO standard for quality education states as thirds: well-equipped physical infrastructure, top-class trained teachers, library and IT rooms stocked with books and computers, 24 hours internet connectivity, entrepreneurship center, where skills are taught, adequate water, sanitation, and hygiene facilities, 24 hours power supply, students' health clinic, security at its best. At St. Matthew Royal College, a mixed boarding secondary school, where principal and staff are accommodated within the premises for a better eagle-eye supervision of the students. St. Matthew's Royal College, Ejenu Ewu Urome Road, Edo State. For admissions and inquiry, 0706-832-9756. Visit our website, stmatthewsroyal.com/admissions.
Get into this beautiful pasta. Chicken soup, juicy looking prawns. Thank you. Spicy fish is here. If you're in Lagos, you need to check out this place. It's beautiful. Oh. I don't want to be an amebo, but you guys have to see this. You? Girl, I'm just trying to give you good content.
Get 2 GB data plus 1 hour YouTube free on Airtel Super Binge Plan. Dial *141 *514# now.
Airtel, the smartphone network.
What is happening? Your eyes are red. You are armed with a machete and a gun.
See, I am angry and I can't even contain it. See.
Oh, my guy, calm down, calm down.
See, okay? I have planned to go and destroy these people's businesses in the city. I have to retaliate for what they've done at our own place. They cannot eat their cake and have it now, never.
If you destroy their business here, and they destroy that of those close to you over there, especially that your brother who sends you steady cash, how would you survive? Would your dreams be on hold?
See, what you're saying is correct. But I'm still angry.
The best way is to embrace peace. With peace and unity,
My people, let us embrace peace and unity. Let's learn to live as brothers and sisters for a progressive, prosperous nation. This message is brought to you from the Federal Ministry of Information and Culture.
Our pastors, our imams, in every church, in every mosque, please realize that in the course of praying for peaceful and transparent elections, we all have duties beyond prayers. If we want a stable society before, during, and after the elections, what should you be saying to those that worship with you? All Sundays and all Fridays, you are saddled with the responsibility of bringing up good generations. It is therefore your duty to both man and God to ensure peace all the time, no matter about elections alone. People talk to people and people listen. Talk to your followers. Make them listen to ensure peaceful 2023 elections. This message is from the National Orientation Agency.
Welcome back. You're watching Good Morning Nigeria this Friday on the network service of the Nigerian Television Authority. Let's quickly take a bit of business news now. And if, all things being equal, the appeal by the Ministry of Transportation to the Nigerian National Petroleum Corporation to assist in establishing the national shipping line, if it does come through, that means we may be, of course, seeing that realized. But let's have details from Kunle Adeyi on Business News.
The Minister of Transportation, Muazu Sambo, emphasized that a strong alliance with the Nigerian National Petroleum Corporation Limited would ultimately secure the establishment of a strong and sustainable national fleet in 2 months. The minister dropped the hint when he received an interim report from the Nigerian Fleet Implementation Committee, NFIC, on the need for the establishment of a strong and sustainable national fleet. He was quite categorical that if Nigeria, as a maritime country, could get its act together, it would not necessarily need the contribution to survive. The chairman of the Fleet Implementation Committee, Emmanuel Jime, said the committee was constituted to implement the recommendation by a ministerial committee on modalities for the establishment of a Nigerian fleet. Jimmy remarked that the initiative was a way of responding to the non-participation of Nigerians in the carriage of the country's international cargo, as well as the loss of freight revenue, jobs, and other benefits. And to the details of Thursday's tradings on the floor of the exchange. With business news, I'm Kunle Adeyi.
Many thanks, Kunle Adeyi, for the business package on Good Morning Nigeria. Up next is Newspaper Review.
Right, we have two papers to quickly look at this morning. And Friday, Al Jazeera, of course, is leading with the wranglings, internal wranglings within the PDP. And there you have it. Atiku Wiki rift, PDP BOT chairman resigned. It comes with two riders. Wabara replaces Walid Jibrin. Exit not enough, says Rivers Governor. NEC passes vote of confidence on Ayu as Wabara forecasts Atiku's victory. That's the lead story on the front page. To also look at other trending stories, let me just take you a little below the nameplate. And that's, of course, the trending story across the world at this moment. Most newspapers, of course, are bearing that as their headline banners. But this Al Jazeera Friday has it just above, a little below the nameplate. There you have it. Queen Elizabeth dies at 96 after being with 15 MPs. That's details of that you can find on the Al Jazeera's version of the story on page 19. Let's come down now to the columns. And on my right, that should be to your left, we have Nigeria gets $700 million as World Bank disburses $31.7 billion. So again, Nigeria is to get $700 million. As World Bank disburses $31.7 billion. We don't know if that has hit us now. Okay, DSS raids hostage negotiators' residence, office, seizes computers, others, and so much more. And federal government urges stakeholders on school safety guidance. That story you can find on page 9. And on the other side of the column, that's to your right, to my left, to your right. Bengasen threatens to shut down sector over oil theft. It's on page 24. ISWAP attacks Boko Haram terrorists, fleeing bombardments in Borno. And of course, the last one there, Imo government receives report on Izombe mayhem. It's on page 10. That's the outlook of Al Jazeera Friday. Kingsley.
Okay, let's just take a look at the window page of the Daily Trust newspaper. On the front page, of course, it's a tribute to Queen Elizabeth II, who passed on yesterday at the age of 96. So, Queen Elizabeth II, 1926 to 2022. You have a number of writers, Buhari, world leaders pay tributes. Life and times of longest-serving monarch, her ties with Nigeria, how King Charles III will be unveiled. You have details on pages 4 and 5 of the paper. Now, above that, you have the following headlines. Insecurity. After clearing operations, FCT schools ready for resumption. PDP crisis, NEC passes vote of confidence on AYU. DSS recovers military uniforms, huge cash from Mamu's house. That's Tuko Mamu. Yesterday, of course, we had the same story, and we had a discussion around it. There were some questions that were raised with regard to the arrest of Tuko Mamu in Egypt and his eventual repatriation to Nigeria. Now, the story from the Daily Trust is further clarifying that on page 9. The story says that he was repatriated from Egypt to Nigeria with his 2 wives, and those 2 wives, of course, who were with him, had been released and returned to their Kaduna homes, while the publisher and his oldest son, Faisal, and his brother-in-law are still in custody. So that's the part of the latest in terms of the developments on the Tuko Mamu story, aside, of course, from the headline indicating that the DSS had recovered military uniforms and huge cash from his home. There's a story that is also a continuing one. You'll find it on page 24 of the Daily Trust newspaper. And it says NMPDRA and NNPC differ. This is on the volume of refined petroleum products. That's more particularly petrol that is trucked out. Now, the Midstream and Downstream Regulatory Authority has said that the average daily truck out of petrol was 66.89 million liters from January to July this year. Now, the story says this is different from the figures from the NNPC, which said that daily petrol supply up till August was 68 million liters. So you have that discrepancy there. That's nearly a million liters, 1.11 million liters. How then do you account for it? If you recall, the Comptroller General of Customs was at the House of Representatives Committee on Finance for the MTF defense and clarification, and they raised the question. If you say that there is a shortfall, or sorry, that you have excess truck out, how many trucks would you require to smuggle out those petroleum products, namely about 500 trucks. So, but the authority, that's to say the midstream and downstream sector, is saying that from January to July, average daily truck out was 66.89. NNPC says 68. So even if you were to take these figures, how would you reconcile 1.11 million liters every day? And you multiply that by the number of days that we had from January to July. NNPC, of course, had issued a statement to say that they were ready for a forensic audit of daily truck out of petrol. And the response, of course, was that Nigerians are virtually tired of all these forensic audits. And so just get the figures right and put them out there.
Precisely.
Yeah.
Well, I don't think the issue we would have revealed would have been the passing away of the British monarch, but that's part of our conversation, in today's program. So we'll just
we will not have. Yeah, of course, we won't talk about that
we'll talk
now.
about that
because I just want to raise another issue, because again, it's a running story on page 25. It's a business copy, and it has to do because yesterday, Kiran and I were on set, and the Nigerian government already warned foreign airlines through the Minister of Aviation from selling airline tickets in dollars. Now, we have a story here saying $464 million blocked funds. Travel agents slam airlines over exploitative fares. They are saying, of course, everybody knows that airfares out of Nigeria for the length of hours that you are supposed to fly are the most exorbitant anywhere around the world. And that despite the release of about $265 million by the central bank from the trapped funds, the airlines were yet to open their lower inventories, thereby leading to high fare rates by air travelers. This is according to the Travel Agents Association, Mrs. Susan Akbarai. But that the airlines are not charging their fares in dollars. But the fact that lower inventories, that's to say the cheaper tickets are not available to Nigerians, means that the airfares continue to be exorbitant and prohibitive. And that is unfair.
It's unfair, and well, I guess we will keep an eye on that, and of course follow, the trends. So that will be the end of our newspaper review for now. Don't go away. We have the first part of our conversation coming up very shortly.
You're watching Good Morning Nigeria on the network service of the Nigerian Television Authority. Now, to our first conversation, which is on the primary healthcare and emergency medical services, let's listen to a background report by our correspondent, Ekene Unduloi.
More than 11,800 road traffic casualties were reported in Nigeria during the fourth quarter of 2021. Out of this number, around 10,200 were injuries, while 1,700 were registered deaths. It is estimated that 50% of fatalities on roads would be averted if ambulances were available to take victims promptly to hospitals. Filling the gap in emergency services was why the federal government launched the National Emergency Medical Service and Ambulance Scheme. The system is designed to provide prompt response to medical distress calls of all types, with first responders transferred to facilities and assured first aid at the point of care at no immediate cost to the user. In February this year, a memorandum of understanding was signed to this effect. The MOU was jointly signed by the Minister of Health, FCT, Federal Road Safety Corps, National Health Insurance Scheme, Association of Nigerian Medical Practitioners, and Guild of Medical Directors. Consequently, the Federal Ministry of Health inaugurated the Emergency Medical Treatment Committee and National Emergency Services and Ambulance Scheme. The routes designed for this project are Abuja Lokoja, Lagos Ibadan, Doka Kaduna, Onitsha Oka, Lagos Ore, and Abeokuta Lagos highways. But for this scheme to be effective, experts say there needs to be improvement in the quality and accessibility of primary health care in Nigeria. Apparently, the situation is far from the desirable, as just about 43% of Nigerians have access to quality primary health care services, with just about 4 doctors available per 10,000 people. In March this year, key players in the health sector converged on Abuja to launch a 10-year primary health care guideline aimed towards revitalizing primary health care in Nigeria. It's been several months since these initiatives were taken. The question now is, how far has the health sector gone in implementing these programs? On this episode of Good Morning Nigeria, guests shall be speaking to issues around primary health care and the Emergency Medical Services Ambulance Scheme.
And to lead our conversation this morning in this regard, we have joined us live here in the studio, Dr. Osage Ehanire, who is the Minister of Health. We're glad to have you with us as always, Honorable Minister.
Thank you for inviting me.
And also joining in the conversation, Dr. Abubakar Tafida, Mandate Secretary, FCT Health and Human Services Secretariat. Good to have you with us.
Thank you. Good morning.
All right. Also in the studio here is Dr. Felix Ogedegbe. He's chairman of the National Emergency Management Treatment Committee. He's also the CEO of Cedar Crest Hospitals here in the nation's capital, Abuja. Dr. Ogedegbe, we're glad to have you this morning.
A very good morning to you. Thank you for having me.
All right. And joining us from Dutse, that's the capital of Jigawa State, I would like to welcome Dr. Kabir Ibrahim Aliu, Executive Secretary of the Jigawa State Primary Healthcare Development Agency. He's also a member of the Executive Secretaries Forum. Dr. Aliu, welcome to the program.
Thank you very much, everyone.
All right. Gentlemen, once again, it's our pleasure to have you. Let's begin with the Honorable Minister of Health, Dr. Osage Ehanire. The emergency medical services, I know it was long in planning, but it was launched in the first quarter of this year. And here we are. We've done probably about 2 quarters now of the operation of the emergency medical services. What's the feedback?
Well, the feedback is the launch of the pilot scheme, which will be the FCT, where we can observe the working and the progress. We are working here on what we call a greenfield. There has not been a coordinated service of this type before in our country, and it requires a lot of planning, a lot of preparation, a lot of assets, and they're putting together the methodology and the processes, first to realize the concept, and then to manage the claims that are going to arise. Remember that service will be given at no cost to providers, to end users at point of care. But the management of claims has to be very well organized so that people are confident that they will get reimbursed for their expenses. And also the systems around call management and dispatch of ambulances. Remember also that we're working using not only government assets but private sector assets. It's a very unique collaboration between the public and private sector to be able to cover the whole country. Government assets alone will not do that. So the private assets are going to be working very closely with government assets to put everything on the table to realize this objective.
What is the link between this emergency ambulance service and the current indices, health indices, especially as it affects the vulnerable group?
Yes, that's a very good question. The indices for Nigeria have never been good. When you go to international fora, you hear of very poor indices in things like maternal mortality, under 5 mortality, etc. Even in TB and other subjects that are not necessarily emergency. Now, the reasons for that are twofold. Number one is the availability. Is the healthcare center available? Can people reach it? Do people have it at all? And that's why we're also working to expand the coverage of primary healthcare centers and also to improve the services provided by general hospitals, which are the secondary level of care. Then the next problem that you have to face is the question of access. Even if you do have the center available, can you get there in an emergency? Can you get there when you really need to? And especially at night, especially also at times when the distance is too much to just walk. So that's where the emergency medical service comes in, to provide access to those who require treatment in emergencies so that you get support at the time you need it and at the place you need it. Of course, the final problem there is the affordability. Now you have to pay everything out of pocket. Now, there must be a mechanism by which if you are very sick and you have no money, or even if you have money but at the time you need it, you don't have money in your pocket to pay, you can still get treatment, you can still get attention. And that's why the mechanism of paying for service comes in, so that nobody is asked to pay at the point of care.
All right, thank you very much, Dr. Osage. And let's bring in Dr. Felix Ugwuregbe, who is chair of the Emergency Management Treatment Committee. Dr. Ugwuregbe, what's been the experience with the launch of the pilot phase?
Yes, thank you very much. So just like the Honorable Minister has stated, there's a lot of work that's been going on at the background, trying to get this in place and get it right. There's a lot of work that you need to do, particularly when you're bringing a novel idea. A lot of people still don't understand how the emergency medical services work. But one of the driving goals here, as has been stated, is that people will not require to pay. We know that there are people who actually need emergency care and they don't have money at that point. So we're trying to really work out those mechanisms where they don't have to pay at the point of care and they still get that good care. So a pilot has been done, and another pilot at the FCT here, and the Secretary of Health of the FCT is here with us. Another pilot is being planned for next week. We've used these pilots, we're using these pilots to make sure that a lot of the problems that may arise at the point of launch are seen, and we provide solutions to those problems. So the idea is to actually scale it from a launch. So we plan to launch from the FCT, learn some of the teaching issues from there, and then we then begin to expand to the rest of the country. So we expect people to actually understand what we're bringing on board. It is new, and it is something that we are fashioning to be a sustainable improvement in healthcare access. Thank you.
At what level of healthcare do you think this service is mostly required? And I ask because the indices we're getting, the health indices we're getting, that gives us cause for concern, is really, it cuts across, levels, but most critical at the, local government, at the local primary healthcare level.
That's correct.
Yes.
Yes, so the emergency medical service itself is a special kind of care. You usually traditionally divide the levels of care into primary care, secondary care, and tertiary care. And anywhere this does not actually work, emergency comes in. So, I mean, if you take, for instance, people getting up on the morning like this, going to work and all of that, and somebody has an accident, or somebody suddenly develops a cough, or somebody has a medical emergency at home, that patient gets picked up, and that patient is delivered to an appropriate urgent care center, which is already predetermined, which is what we're doing. We've registered centers that are able to provide that care, and this is already predetermined, so we know where each kind of problem can go to. So the emergency delivers to that center, and that patient is restored. So you basically revert that emergency threat to life. And once you've done that, the patient can then return to his primary care center, secondary care center, if the care needs to continue from that point, or tertiary care center, if it's such a thing that the definitive care needs to be done at high level. So emergency comes to complement all of these levels of care.
What kind of emergencies? I don't say, would you be anticipating from the primary healthcare level to use the emergency services?
So, for instance, at the primary health care level, we already talked about the poor Nigeria indices in maternal mortality and infant mortality and all that. It does seem that part of those indices have to do with inadequate transport and access for women who are pregnant, who at night, go into labor, begin to bleed. Those basic kind of obstetric related care, for instance, infant care. An infant suddenly develops a fever and gets ill. If it's during the day and if it's not so bad, they go to the primary care center and they are looked after. But if it's night and if it just happens all of a sudden, you will need the emergency service to then deliver them to care. So those kind of maternal child related problems that are typically dealt with at the primary care level would have a lot of impact being made by the presence of an emergency medical service.
All right. Thank you, Dr. Godegbe. We'll bring you into the conversation shortly. Dr. Abubakar Tafida, Mandate Secretary of the Federal Capital Territory. I recall we had you here on Good Morning Nigeria when the pilot was rolled out in the Federal Capital Territory. What's your evaluation of the pilot scheme?
Thank you very much. First of all, the pilot was launched in February, where the MOU was signed between the Honorable Minister of Health here and our own Minister of the FCT. Like Dr. Felix said, there were a lot of issues that you have to consider for a novel program as we are doing now. And I gave an example of the NHIS, which was started way back in 1955, and it was only formally launched in 2005. So as we moved along, thanks for the leadership of the Honorable Minister of Health, who often calls us to ensure that we are on track, we had to look at the critical issues that must be in place for such a program to be formally launched. One of them is that we have the structure to manage this program at the FCT level. Yes, we have our own EMTC committee, which gives the oversight function, and we have the program implementation unit, which is the MSAS for the FCT. Yes, we have. And graciously, our Honorable Minister gave a directive for us to engage 66 other personnel directly to be involved in the training and managing the pilot program. This includes 24 nurses, 2 doctors, 16 drivers, and other ancillary staff. Now, as we move along, we now look at the call center. What do you need to have in the call center to coordinate the activities of this program? Unfortunately, everybody is in the FCT. You call it, the federal ministry is here, lot of private sector with the public sector, the tertiary institutions, National Hospital, JIB, FMC, and so many others. Of course, you have NEMA, you have the federal reps. We've been sitting and discussing and fine-tuning the process of making sure that this thing goes well when it is piloted. So as it is now, part of the other issues are, have we taken access, have we make an assessment of asset and infrastructure to ensure that this program runs as smoothly as is possible? And the answer is yes. We are going to be part of the accreditation together with the federal team. And in that accreditation, each facility will be assessed based on what services would be provided there. If you take a patient, for example, to a facility A, does it have the capacity to resuscitate, to continue to manage, to do whatever is needed to ensure that this patient is getting well, and does it have the capacity to rehabilitate the patient? So that would be the full complement of what is needed along the process. And like what the Honorable Minister said, for the first 24 hours, nobody will be asking you to pay a penny. That is the critical issue. So emergencies are now increasing by the day. We are not talking about road traffic accidents. We are talking about obstetric emergencies. We are talking about domestic incidents. We are talking about assault and so on and so forth. So how do you make these people or have them access service as quickly as possible? The first dry run we did, we realized that the shortest possible time where an ambulance moves to a particular point to pick a patient was 3 minutes. But the longest time, unfortunately, was 24 hours. It's not about the coordination, but about the technology. We needed the technology to ensure that the right ambulance within the shortest possible time is contacted and dispatched, and the appropriate personnel are there with the full complement to resuscitate, assess, resuscitate, and then quickly convey that patient to a particular emergency center.
Yes, let me put you on hold, Dr. Tafida.
Yes.
Thank you for your explanation, and bring in Dr. Kabiru Ibrahim Aliyu, who is joining us from Dutse Center, and he is the Executive Secretary of the Jigawa State Primary Healthcare Development Agency. Dr. Aliyu, thank you very much for joining us. The Primary Healthcare Development Agency, it's one of the strong pillars, to drive the goal on, attaining good health and general well-being for all Nigerians. That's the SDGs, by 2030. Recent evaluation of progress made so far indicates that there's a wide gap between the good policies, federal government policies in the health sector and implementation at that level, service delivery at that level. In some areas, they say it is critical, that service delivery. At other areas where you have access, you have poor services. Can you give us, a sense of understanding of what access to primary health care in Jigawa is?
Okay, thank you very much. I'm pleased that I'm part of this discussion. You brought a very important point with regards to issue of implementation versus policy, the hitches, and all that. From our experience at the local level here, what we realize is that most of the issues related to provision of core primary healthcare services basically related to provision of acute care services for common and endemic diseases, control of endemic diseases, provision of maternal and child health packages, such as immunization, antenatal care services, skill delivery and family planning, water and sanitation issues, health education, provision of essential drugs. These are core PHC functions. And what is actually required for these functions to be delivered are issues related to strong partnership, intersectoral collaboration, using appropriate technology within costs that community can afford by engaging the community actively to participate in this process. So putting all this paradigm together, you realize that what we see are challenges related to coordination of primary healthcare services and interventions. The major problem for now implementation arena, as far as PHC is concerned in Nigeria, are related to coordination. For the first time ever, we have seen huge effort by the central government revamping provision of funding and also technical oversight for PHCs across the country. The implementation of the Basic Healthcare Provision Fund using the 3 gateways, the primary healthcare gateway, the NHS gateway, as well as the medical emergency gateway, is actually a game changer as far as the PHC funding is concerned. But the challenge in implementation is actually related to coordination. We've been seeing issues related to inability to coordinate partnership, inability to have this sectoral and intersectoral collaboration we're talking about. We have seen verticalization of some interventions right from the federal instances where you see programs coming directly to the community and being implemented from the federal agencies without having recourse to some of the local people within the state. And then the recent passage of the local government autonomy bill is also another challenge to the coordination platform for provision of care. While you are trying to provide that oversight, coordination, and technical input, you also have other key players that are the owners of the facility. Now they're talking about they have fiscal responsibility and fiscal autonomy in the provision of this care. So managing these circumstances, local government autonomy, verticalization of programs, donor coordination program, are actually the major challenge in the provision of care as far as PHC is concerned. Localizing the matter to Jigawa State, we had to go through a lot of innovations to make sure that the services are actually not affected by some of these issues that were mentioned. We have to provide a lot of innovation. For instance, talking about medical emergency, Jigawa State has introduced emergency community transport scheme, in which not only we are waiting for the launching of the ambulance services, but we have engaged people who have anybody who has a vehicle and the vehicle is in good shape. These people were organized, were actually trained, and were be linked to the communities where they can provide services for transportation to especially pregnant women and other emergencies at the community level, especially in high-risk settings. We made a provision of 4,000 naira per trip of this kind of services. So each driver that brings a pregnant woman that is in need of maternal services, that person is credited with this amount at the end of the month. And with this, we have engaged over 300 drivers. Last year alone, we transported over 1,400 women under this scheme. And I'm proud to say that within last year, among those women that were transported to health facilities, we only had one maternal death among those who were actually transported, because the transportation took place at the time that these people are actually in need of these services. We link the drivers to the members of the community and all that. So we're talking about creation of innovation, we're talking about strengthening collaboration and also stronger coordination, especially federal agencies, the state programs, as well as donor program, to ensure that these resources are galvanized together so that the common man really feels the impact of what we are doing. Otherwise, you realize there are a lot of duplications, and there are areas that are never ever touched because of this poor coordination mechanism that we see. The primary healthcare under one roof has made huge attempt to bring primary healthcare under one roof and provide that coordination platform we're talking about. Like I said, this is being challenged by local government autonomy as one aspect, and there are many other key players within the PHC system that are outside the spheres of the primary healthcare signature, such as water, engineering services, which we need stronger collaboration, the budgeting process, the appraisal mechanism, actually all different, and we need to really look at the issue of coordination as a matter of urgency for this core services to be provided at the optimal level. Thank you.
Thank you very much, Dr. Aliyu, for the insights you provided into what's happening in Jigawa State. I want to return to Dr. Abubakar Tafida, who is of the Federal Capital Territory. I know that this is probably you have a much more elaborate report on this, but could you decompose the data for the benefit of our viewers? For how long did you intend to run the pilot scheme or the pilot project? And what has happened in the course of running the pilot project? For instance, how many calls, if you have the data, how many calls did you receive? You've talked about response time, shortest 3 minutes, longest 24 hours. What happened in terms of calls? Where did most of the calls come from? Were they from AMAC, which is the municipal area council, or from, because you have 6 area councils in the federal capital territory, and more particularly, what kinds of emergencies were your men called upon to respond to, at what times?
Unfortunately, I cannot give you most of the answers because what we did was a dry run. What we mean by that is that it's like a calculated amount attempt at simulating what should be the real. So we took cognizance of the key facilities within the FCT. So if you look at Kwali and Gwagwalada, we have the University Teaching Hospital. And we also take cognizance of certain facilities in Kuje, the FMC in Jabi, and Asukuru, Metama, and Wuse. So the pilot was centered around placing ambulances in strategic positions in these areas so that they now receive a call, a dispatch, informing them of an emergency for them to rush that person to a particular facility. So right from the moment the call was sent, the dispatch received, the response, the ambulance will now rush that particular, we are not picking patients yet. They will now run as quickly as is feasible to get to the closest facility where they will now convey that particular patient. So with that, having learned the encumbrances and other challenges encountered, the next pilot, which will be next week, will have the full complement of having the dispatchers there using their computers. The only setback we have is that we are not yet linked to the computer-assisted dispatch system, which I'm happy to say the Honorable Minister has promised to graciously provide for us. So with that, we are now also coming back to, instead of taking the whole FCT as an entity, we are narrowing down to Metama and Asokoro, and possibly Wuse, so that we can now control what happens and what are the key challenges. Because even when we are formally launching, I believe the Honorable Minister will give a possible time for the launching.
Why use Metama
exactly.
and Asokoro?
Will it give you the correct outcome of what you're looking?
Remember, this is a novel thing. If you take a huge area, you are learning perception, you are learning of what the challenges would be almost impossible to tackle. If we said we are taking Metama, Asokoro, or Wuse for the first few weeks, you will learn a lot. And from there you add on. We are lucky the FCT has neighborhood, sectors, districts. So we begin to add district by district. It's not possible. Currently we have 27 accredited facilities, private, including our own main 14 hospitals with the ambulances. So to coordinate this and then escalate it for the whole of the FCT, that we are expecting to have about 100 ambulances, it's not possible.
So let me get to Dr. Tafida.
Yep.
You're saying that the pilot scheme of the emergency ambulance medical services, whichever, it's already operational in the FCT.
We already have a department which was running a skeletal emergency services. Remember, the Federal Road Safety Commission is having the same thing.
That's the one we see.
We are now coordinating all of these activities into a single system. And for you to have that, if you don't have a very good communication system, there are specific softwares that will be managing both the calls, the movement of the ambulances, and what happens in the centers, the emergency centers, where the patient will be taken, and how they are managed, what time it was taken to respond, and so on and so forth. I can bet you it's not something that you will start for the whole FCT in a single day, in 1 month, and so on.
I think, Dr. Tafida, the expectation is that for a pilot, even for the Federal Capital Territory, you will have appropriate segmentation. To say that we're taking a slice of the FCT. There are 6 area councils in the FCT.
Yeah.
Perhaps we'll kick off with one area council, and even in that one area council, zero down. I'm raising this. Hang on a second, Doc. I'm saying this. Just hang on a second, Doc. I'm saying this because you also have to deal with public perception. I mean, our viewers are listening to you now. You say you want to start a pilot from Maitama and Asokoro. The next thing you will hear is that yes, absolutely.
See, I think
you now begin to struggle to win and then to get your buy-in and so on and so forth.
You have a misconception of what we are trying to say. If we are saying we are making a pilot, you don't want to start something that will crash. That is the truth. And now I will tell you, AMAC alone has 54% of the population of the FCT. And we are talking about over 2.67 million people. So if you are not saying, okay, I'm going to take AMAC, the whole of AMAC, or I'm going to take Buhari, or no, I'll leave it to go to Kwali. What are you learning? Let me say this, Dr. Kabir there, who was talking about the local transport. I happen to be one of the initiators because I was then serving as commissioner in Jigawa State. The issue is that at the local level, the Basic Healthcare Provision Fund is already providing services for the vulnerable and the indigent. The idea is that every pregnant woman...
services?
No, we are coming to that. If you see, for every 100 pregnant women, the expectation is that between 5 to 10 of them will end up with obstetric emergencies. These are known. So by capturing these women to attend their antenatal care, to have their immunization and so on, you are now already monitoring the likely number of women that are at risk of developing emergency obstetric care. What Dr. Kabiri was saying there is that in remote villages where there could be just 1 or 2 vehicles, an arrangement is made such that at any given time a woman is going into labor, or if there is any emergency, that driver will quickly pick up that, often at night, to take to the nearest facility where emergency services will be provided. And for that, an incentive is given. In those days, we only give them opportunity to go and have first come, first serve issue in terms of taking on their passengers. So if you say now that in the FCT, we are expected to begin with the whole of maybe AMAC or the whole of the FCT, like we are not going to learn much. We may end up.
I don't think. Sorry.
Collective decision.
No. I don't think. Just listen. If you listen to our questions, Dr. Ogedegbe, nobody said. I mean, in research, if you are conducting a research, you have a sample size. That's why I said that there will be segmentation. If you say it's a pilot, you take the Federal Capital Territory. There are 6 area councils. You want to take maybe 1 or 2 area councils. Even when you take one area council, say it AMAC, Kuje, Kwale, or whatever it is, you are not going to every nook and cranny. You further segment it. And I raised the issue of public perception. You say you are kicking off from Metama and Asokoro. And I said, look, in public communication, people are likely going to say, oh, it's only big men who can be taken in and then later they will pay. I would ask the question, for instance, why don't you narrow down to Gwarinpa and Lokogoma? I don't live in any of those places. But I'm saying that in terms we're interacting so that, because there are people, there are viewers who will be saying to themselves, oh, why don't you use some other areas? I mean, Gwarinpa comes up sometimes with all kinds of health issues from time to time. Yes.
To buttress what you have just said, this is a recent evaluation report. I'm sure the minister is aware of this. It's a comprehensive evaluation report that was presented recently, and it says equity gaps during pre-pregnancy and pregnancy between the rich and the poor. And in antenatal care, you have a gap of 54%. That's 31% poor, 85%, for the rich. These are the access gap, percentages, and the gap is 54. So if you are doing a pilot, one would expect that you will go to these areas, to give you a better understanding of what the challenges, are. And that is why I'm sorry. I want to ask the Honorable Minister. Dr. Aliu talked about partnership and coordination, which he says is a big challenge for them. I would have expected that Jigawa State, for instance, would be one of the pilot states for this service.
Yes. Well, first of all, as has been emphasized here, this is a novel concept. It brings together public and private sector. And we want it in a place where we can all follow it and learn from it. Now, we would like to go to a state like Jigawa, but it will be a bit remote for us to follow in detail how it's functioning over there. But that will come up later on using lessons learned here. But this whole discussion now already exposes weaknesses in the system that we inherited, in that there's always been an urban-centric drift in everything we do. Exactly. The most functional hospitals in this country are the tertiary hospitals. General hospitals are almost not functional. The primary care centers are also not. And these are the most important. So this government, this administration has been trying to draw attention to primary and secondary care. And because that's where the problem is.
Precisely.
The maternal mortality, the under 5 mortality, and so on. So getting everybody to key into that is what is being exposed right now. And of course, we are going to learn as we go along. We are also getting our development partners to join us and put emphasis in care at the basic level, at the rural level. So talking about the pilot, yes, we should do two things. Number one, work with the private sector, bring the private sector in. Number two, have a representative sample size everywhere. Should be representative. So that's part of the lesson that we are going to learn in doing the dry runs and doing the tests that we're talking about, in order to know how to make it fully functional. Right now, if you live in a rural area, you are less likely to have access. You're in fact less likely to even have a maternity near you that you can access. So that's a problem of availability. And that's why we have been emphasizing bringing up the primary healthcare center to standard, to function 24 hours a day, to have staff quarters, to have water and light. So that takes care of availability. Then the access of it now is what this entire emergency medical service is about. And finally, the affordability. How do you pay? That's why you have the Basic Healthcare Provision Fund and then the National Health Insurance Authority, which His Excellency the President has made possible in these two cases. So the financing is potentially there. Then the access is what we are creating now. And then the availability is what we have been trying to to provide by creating also urgent care centers, which can be private, can also be public.
All right, thanks. Dr. Ogedegbe, I know you've been itching to say something.
Okay.
No, just Dr. Ogedegbe, and then we'll come back to you.
Yeah.
Yes.
Okay. So I think the discussion here we're having is a very important one. Part of what this helps to achieve is to get the public to be properly informed on what to expect. The National Emergency Medical Service and Ambulance System is meant to be a nationwide system. We must understand that from the beginning. And nobody is going to stop at any point until that is the case. I was going to throw this in, but it's been asked, why pilot in the FCT? Why not pilot somewhere else that is more rural than the FCT? We want to be able to have a grasp of what is going on, because there's a lot of coordination in the approach that we have taken. Be reminded that emergency medical services exist in other countries, and some are running for up to 50 years. The Americans started in the 1970s, for instance, and they've learned a lot of lessons, and we have also looked at their results over time, and they've not even stopped learning. They've kept modifying. And you've already mentioned, the Honorable Secretary has mentioned how long the NHIS journey is till the point now we're getting to NHIA. We are trying to look at how other agencies or similar endeavors have traveled. The best approach is to limit to a geographical area that you can control and learn the lessons. In this, our approach with the Honorable Minister is leading us to achieve. There's a very key coordination with technology. So you're looking at using the card, which is a computer-aided dispatch system, where a call comes in, the computer tells the ambulance where to go. And the ambulance drivers, remember now, it is no longer only the concept of the nearest hospital. It's the nearest appropriate center. If in the FCT, for instance, let's just give you an example, there are 2 centers that treat burns. Maybe one is Gwagwalada, and the other one is Asokoro. All cases will go there. So they are not going to come to my hospital, which is a private hospital, which is not accredited to treat burns. They will treat the patient on transit until they go to that. So once they hear burns, the computer knows where burns goes. The drivers knows where burns go. Everybody knows. So it's a novel approach, and it's a very technology-based approach. And luckily and thankfully, the FCT, like you've mentioned, 6 area councils, they've broken down to districts and a lot of that. We are able to monitor and get the lessons and quickly spread. Anything other than that, people have shown doesn't really work. Once you learn lessons from a strict, clearly controlled geographical location where all your calls work, by the time you're not going rural, you're not saying, okay, if call doesn't work, there are phones now that you know abroad, when you press 911, you don't have to have credit, you don't have to have this, you don't have to have network in some places, and they will still pick you. But you need to learn from the urban, and then gradually, so you now know out of 5 things that work in Asokoro, for instance, when I go to Kuji, 4 will work, 1 won't work. So how do I mitigate against that one? We have to learn lessons in a clearly scalable manner. I mean, there are a lot of interest from all the states. Right now, the national program manager, who should have been here, is actually in Lagos, and I had to leave Lagos yesterday for him to go to Lagos because the Lagos state government, even though they probably have the most advanced emergency medical service in the country right now, they're taking on this NEPSAS approach fully, and they've invited us. We're sitting with them today, to look at. So we don't even know which state will come next after the FCT.
Apart from the call
Yes.
issue, what other lessons are you expecting, or feedback are you expecting from the pilot that's going on in the FCT?
So that's the other thing I would say. Let's be very clear to distinguish between the dry run and the pilot. I think there's a confusion about that.
Yes, I know.
The dry run is that you're not actually taking sick patients. You're positioning patients, positioning ambulances, and positioning urgent care centers waiting to receive people.
So what you're doing now is dry run.
So we're doing multiple dry runs now.
Okay.
And I thought there was some confusion about that.
Okay, multiple dry runs.
Yes.
And when will the pilot
So when the pilot then starts, the pilot is now taking actual sick patients.
When will that start?
So that is being, and we will be able to give a definitive date, and the Honourable Minister is going to say when we can actually flag off the FCT pilot after the dry run next week.
Okay, so now, sorry.
Yeah, go ahead.
So now, let us into what your discoveries with the dry run. Yes.
Like I was saying, I think there was a misconception of discussing the dry run and then a pilot. Where I was saying we did the first dry run, and it covered a wide area, including all the way from Kwali down to Buhari and here the FCT. So from what we have learned there and the challenges we observed, we now want to, or we plan to conduct another dry run with the improvement we have made within the system, but restricting it to particular districts so that we will see whether these improvements we are infusing into the system has worked well. So once we are able to get that, we have made our analysis to say that, yes, these are the encumbrances. For example, if you are taking a patient from point A to B within Metama, for example, or Wisi, or Asoko, that would give you a time to think that if you are dealing with somebody in Kwali, for example, or Gwagwalada, will it be shorter or longer? And then what number of private facilities have we accredited to work with us in so-so and so-so places? And what will be the number of these facilities working in so-so and so-so area? So it's very, very critical. And like I said, with the Basic Healthcare Provision Fund, things are now being taken care of at the primary level. We are talking about revamping the primary health centers, like in the FCT, all the 62 PHCs benefiting from the Basic Healthcare Provision Fund are being revitalized, and more human resources are being infused. And as you know, Honorable Minister, we've just recently launched the non-communicable disease, the MPEN program, where people now can access management for hypertension and other cardiac related. The idea is that you are able to monitor right from the primary care level. And if there is any emergency, somebody there has a medical history and is able to link up with the emergency transport system.
Okay, fine. Thanks a lot, Dr. Tafida. Honorable Minister, I'd like you to clarify this because I recall raising this question when we were discussing the access to emergency medical services. Because I keep, and it's the point has been also been made today. We keep hearing about maternal and child mortality. You need to take pregnant women who have complications or pregnant women who are in labor to get them. That's why I asked the question, but you said now it's a dry run. Ultimately, when you have your pilot running, what kind of emergency services are we looking at? If somebody has, is that an emergency call, Honorable Minister? we could allow you to take it. I'm sure somebody is trying to buzz you to see whether there will be a response. So there's been a response from the Honorable Minister. Look, somebody is in a diabetic coma, and the family members or those who are around are calling. Can they access this service? Somebody has a cardiac arrest. Can they call these services, or is it only in cases when you call them, they will say, look, now people with now pregnant women only now with the carry, we know the carry people will get all that kinds of ailments. What should we expect in the pilot program?
And is it tied to conditions?
No. The point is that the way a medical emergency service functions is that anyone who has a medical problem, they can be very urgent, sometimes not even urgent, will be able to call only a number, 112. You reach a dispatcher. Is it fire? Is it police? Or is it medical? Once it's medical, you leave the rest to the medical service. Now they will find out what it is. And it can be a woman trying to deliver, it can be a child, it can be an accident, it can be a large number of them, it can be diabetic coma. You've listed all of them. So it's left now for the emergency service to take over the rest. In fact, it can even be an acute COVID infection. Once you suspect that, the emergency service will kit differently. What they will now do is to move in there a team of those who understand the problem, paramedics, and then do the necessary first aid if it is necessary, and then move the patient to the specific hospital where care can be given, where you don't have to go from one to the other looking for which hospital we admit. So that will save time. It will also save lives, and in the sense that nobody's going to say pay money before we treat you. So those services are supposed to be available. But if you disaggregate, take for example road accidents, where the Federal Road Safety, working with this system, is prepared to do that particular service on the road network. We are monitoring that and working with them. Take for example the one we call the rural ambulance service. Those are largely, as we envisage, tricycle ambulances that will be around the primary healthcare centers, that will respond to calls coming from rural areas where people cannot even get to the center. But the center must be available, because it's no use if you don't have a center that can take care of your problem.
That's what I was going to ask you, because
so they're all interlinked.
I don't know how long the pilots will run, considering the state of the primary healthcare centers. But please take that. This will be my last question to you. I just like Dr. Ibrahim Aliyu. So
what's the question to the minister?
Yes, I wanted to know whether the primary healthcare centers, because the rehabilitation and innovation of the primary healthcare centers have been on. Most of them are still not in they are still in deplorable state.
Correct.
Yeah. So we want to know, because you need functional primary healthcare centers. I mean, there's a link between these services and functional primary healthcare center. If you don't have a functional primary healthcare center, what happens?
Exactly. So that's why we have been happy.
Yes. So I'll allow you to take it as your last question. I don't know if Kingsley has, but I would like Dr. Aliyu to explain to us. He said something about the local government autonomy and how it's affecting service delivery at the primary health care level. Can you quickly, maybe in less than 60 seconds, if you may, summarize that so that the minister would also take it up?
Okay, thank you very much for bringing me back again. So that, the Federal Ministry of Health through the National Primary Health Development Agency had been pre-positioning the issue of primary healthcare under one roof as an organ of coordination for all primary healthcare activities. And by this, it means the primary healthcare agency is responsible for infrastructure, for human resource, and for services, and therefore they're accountable for these services. But with the current introduction of the Local Government Autonomy Bill, we're looking at a situation whereby the local government chairmen are now taking back their staff, they're taking back their facilities, and they're providing inputs in terms of appointment of people who are going to handle some of these operations that we're doing. So at the end of the day, you realize you have a situation whereby you really can't hold one single body accountable for failures and challenges. And that is the point we're talking about. We need to really look at how local government autonomy will be operationalized in the context of primary scandal war in Nigeria. Thank you.
Dr. Aliyu, we want to appreciate you. Dr. Kabir Ibrahim Aliyu, Executive Secretary of the Jigawa State Primary Healthcare Development Agency. Thank you for being part of the discussion this morning.
Thank you very much. It's my pleasure having you as well.
All right, so let's come back to the studios and get very briefly the closing thoughts of Dr. Felix Ogudigbe, Chair of the Emergency Management Treatment Committee. We know that this is novel, and therefore you have teething problems, you have misconceptions going forward. Once it kicks in effectively, people are going to look back and say, "Oh wow, now this is what this was all about." But what should members of the public have at the back of their minds as you roll out the pilot phase? The date, of course, we said is not certain yet. What should the members of the public look out for? Where the pilot will take place. Now we hear it's Maitama and Asokoro, but we have also suggested that it could be Lokogoma and Gwarimpa or some other districts in the FCT. Because let's face it, let's be realistic. You see, we know that the FCT, that's particularly Amak, is one of the most livable parts of the country today. But even then, there are access issues into some neighborhoods. And when an emergency arises, it is overcoming those obstacles, bad roads, gated communities, X, Y, Z, that could be the issue. It could be complications in childbirth, a woman is in labor, or somebody had a serious, severe burns, or some other injury or cardiac arrest, and so on and so forth. That's why we are saying, look, yes, vehicles can sneak in and out of Metama and Asokoro. Go to Lokogoma and see whether it will work that way.
Dr. Gedegbe, we have less than 2 minutes to round up, please.
Sorry, so yes, let me just respond to your question regarding what people should look at for. I'm sure those who have experience of living abroad or who hear how things are in other countries understand that emergency medical service, the provision of emergency medical service is what really makes a big difference between countries that have proper healthcare systems and those who don't. Right. So we expect people to look out for emergency medical service that will be provided to look after all emergencies through a number that they'll be able to call. We will start a pilot from a part of the FCT and hopefully scale it up to the rest of the country.
All right. Honorable Minister, you have the last word.
Well, what the discussion is already exposing exactly those problems that we are trying to solve in the country. The imbalance in service provision, the fact that a lot of the service right now is centered in the urban area and leaving the rural areas almost unserved. But the emergency service that we are providing is going to cover the whole country. There's a lot of digital technology involved. You must be able to track every ambulance. You must be able to extend service to rural areas and provide a whole plethora of services that constitute emergencies. So we are working on that, learning from all the experiences that we are making, starting from the FCT.
Do we have yet a central toll-free number? Emergency
yes,
numbers?
We do have that. We are working with National Communication Commission. 112 is the number. You can also use 112 if it is a road accident-specific emergency. But 112 is a number that gives you access to dispatch, and the computer-aided dispatch will help to disaggregate the calls and then send it immediately to an ambulance system that will be tracked where it's going, because we are going to pay them according to where they have gone and what they have done, and the service that was rendered.
Just like you have an Uber tracker or you have a boat tracker.
Excellent.
Exactly. That's right.
Exactly.
You are having a ride and then you are able to communicate and everybody knows where you're going. So on that note, we'd like to appreciate our guests who've been, we're out of time. We have a second topic. Hang on a second, Doctor. We have a second topic and we can't run away from that. We've been pressed to wrap this up for the past couple of minutes. So we will have another opportunity, I believe, to discuss this subject matter. And happily, Dr. Abubakar Tafida, who is the Secretary of the FCT Health and Human Services Secretariat, you are close by, so we can always invite you to elaborate more. Dr. Felix Ogedegbe, we also thank you.
Our next controlled dry run will be at Asokoro Abmetama, but the pilot is going to be for the whole FCT.
We got that.
Thank you.
Thank you very much.
Thank you. As well, Dr. Osage, and the Honorable Minister of Health, glad to have you being part of the conversation this morning.
Thank you. Thank you for inviting us and allowing us to explain this to the public.
All right. It's Good Morning Nigeria live on the network service of the Nigerian Television Authority. We take a short break now. When we return, we'll be discussing the passing of Queen Elizabeth II after a 70-year reign and at the age of 96.